As you all know, this is all about community medicine. And today, what I'm going to take up is something very relevant and something we often ignore as well. So what are we talking about? Today, we are going to take up the screening tests and how to evaluate them as well. So, without further ado, let's get going. Well, first and foremost, for any medical student, what's more appealing? It's, of course, intervening, treating, and directly evaluating the patients. But for all those interventions, making those sea changes, there is a background scenario of assessment. An assessment that involves identification of the population at high disease risk, be it based on demography, family history, and other host factors, and assess the exposure, conduct the research of the mechanisms, including the study of genetic susceptibility, and only then that we really know what to intervene and how to intervene. So, assessment comes hand in hand with intervention. Three terms in this concern are often used interchangeably and thought to be the same. But let me tell you these three terms: screening, case finding, and diagnostic tests. These are much different from each other. Coming to screening, it is a search for unrecognized disease or defect by means of rapidly applied tests, examinations, or other procedures in apparently healthy individuals. So what are the two major thrust areas? Firstly, it is carried out in apparently healthy individuals. Who are these apparently healthy individuals? If you look at the iceberg phenomena of disease, what do we say? We say we only see the tip of the iceberg of diseases. That is the clinical cases with signs and symptoms who seek care. Then what is the submerged part? The submerged part is this apparently healthy, who are not seeking care, and who may be including those cases as well who are subclinical, who may be clinically symptomatic yet not seeking care, and of course those who are healthy as well. So if one thrust area is on the apparently healthy individuals, the other thrust area is the search for unrecognized disease or defect. Now coming to case finding, how is it different? It is the use of clinical and laboratory tests to detect disease in individuals seeking healthcare for other reasons. That means the person is coming to you for some other purpose, and these battery of tests are being applied to detect some other disease. For example, if screening is premarital screening for syphilis, the VDRL test in pregnancy to rule out syphilis is case finding. Then how different is the diagnostic test? It is the use of clinical and or laboratory procedures to confirm or refute the existence of a disease or true abnormalities in a patient with signs and symptoms presumed to be caused by the disease. That means we are carrying out tests to confirm or refute a disease in a patient who is already presenting to you, that is the medical personnel, with the signs and symptoms of the disease. So in the context of the same example of syphilis, in this case, when we carry out the same VDRL testing of patients who are having lesions suggestive of syphilis, it no longer becomes screening or case finding. Then it is treated as a diagnostic test. So mark very carefully, the same VDRL testing, when it is given for premarital screening, it is screening. When it is given in pregnancy as ruling out for syphilis, it is case finding. And when the same test is applied in a patient having signs and symptoms of syphilis, it becomes a diagnostic test. The concept of lead time is very important in this particular setting, that is screening. So when is the screening applied? For that, it is important you understand this timeline of the disease process. First is the disease onset detection. Then is the first possible point of diagnosis. Then is the final critical diagnosis point. Then is the usual time of diagnosis. And of course, then is the outcome or death. Now, this final critical diagnosis point is the point beyond which, when it is diagnosed, the disease concerned, there is no point of reversal, or there is little chance of getting into the normalcy. So what is the ideal screening time? It is between the first possible point and the final critical diagnosis before that. So that is the window where one aims for screening, so that they get that advantage that before the usual time of diagnosis, to have got hold of the disease at a stage where it is reversible, treatable, the outcome is modifiable. And what is the lead time over here? The lead time here in this timeline is between the first possible point and the usual time of diagnosis. That is the advantage gained by using the screening. Now let's take two different scenarios. In this particular scenario, let's look at the black figurine at the top. Here, and as the screening case who is seeking screening, and the purple figurine is the one who is going through the usual practice of being diagnosed in the usual time with no screening. The biological onset of disease for both the persons are at the same point of time. The disease detected by screening for the black figurine is way earlier than the purple figurine, and the perceived survival time for the black figurine is much longer than the perceived survival time in case of the purple figurine. So is it really so that in this particular scenario, screening is actually giving advantage to the black figurine? If you notice carefully, the death outcome for both the figurine is at the same time. So actually what is being visible is a lead time bias, where health outcome is the same in someone whose disease is detected by screening compared with someone whose disease is detected from symptoms, but survival time from time of diagnosis is longer in the screened patient. So make it more evident, let's take up another scenario. In this scenario, the black figurine has a longer lifetime line. So there has been an advantage to the black figurine because of the screening, because of the lead time gained. But what the perceived survival time is in this particular case compared with the perceived survival time in the purple case, it's still erroneous. That is, still there is a lead time bias, because what actual difference it has made, that is much less than the total perceived survival time. So hence it is to be understood very clearly that lead time is only of benefit when it is able to screen the patient before the critical diagnosis time. And even if it is diagnosed within that critical diagnostic time, still the apparent survival time is often not that much more than what actually is in case of a person who is not seeking screening. So what are the uses of screening? Firstly, detecting the cases, which we call the prescriptive screening, which helps us in presumptive identification of the unrecognized diseases. Control of diseases, which is called the prospective screening. That is, the people are examined for the benefit of others, like HIV or hepatitis B screening in the case of blood donations. Research purposes for knowing the natural history of disease better. Educational opportunities, so that through proper public health education, the community is made more aware. So what is a screening test? A screening test is done to detect the potential health disorders or diseases in people who do not have any symptoms of disease. And the goal is early detection and lifestyle changes or surveillance to reduce the risk of disease or to detect it early enough to treat it most effectively. And the screening tests, as we all know by now, are not considered diagnostic. It is used to identify a subset of the population who should have additional testing to determine the presence or absence of the disease. So with that, let us see how it really functions. The screening test, as we have already discussed, are applied on apparently well population. So this apparently well, as we discussed, includes those who are well as well those who are unwell yet undiagnosed. So if this is the population to be tested by the screening test, the result can be either negative or positive. If it is negative, the persons are presumed to be free of disease under study. But if it is positive, the person presumed to have the disease or be at increased risk in future. And in this positive cases, the diagnostic procedures are applied. So those who are positive, the therapeutic intervention takes place, and those who are negative, it is supposed to be risk factor or disease absent. So a very popular question in your exam is the difference between the screening test and the diagnostic test. The screening test, as I'm repeatedly telling, is done on apparently healthy individuals, whereas diagnostic test is done on sick or ill individuals. Screening test is mostly applied to groups and diagnostic on single patient. The results in screening tests are arbitrary and final. Diagnostic test is not final. There may be a battery of diagnostic tests applied. So based on one criteria and cutoff, and diagnostic is based on evaluation of a number of signs and symptoms and laboratory findings. Screening tests are usually less accurate, less expensive, and of course not a basis for treatment. And the initiative comes from the investigator. Coming to the diagnostic test, it is more accurate, more expensive, used as a basis for treatment, and the initiative comes from the patient themselves. So if you look at this, both are tests for tuberculosis. One is the Mantoux test on your left, and on the right is the chest X-ray. While chest X-ray is a diagnostic test, Mantoux test is a screening test. Now, how are these screening tests developed? Are all the diseases concerned have a screening test? No. Here we follow a particular directives as given by Wilson and Jungner in 1968. They had laid down certain criteria. That is, firstly, you can remember this by CT. First C is condition, that it should be a major public health problem. The natural history of the disease should be well understood. and there should be a recognizable latent or early symptomatic stage, whereby if you apply the screening tests at that stage, you can make that palpable difference in the disease course. Now coming to T1, the test should be safe, accurate and acceptable. Remember, screening tests are being applied from the end of the physicians. So the patients are not seeking it. Hence, it has to be safe, accurate and acceptable to be really taken up by the patients. Now T2, that is the treatment. There should be available facilities for confirmation of diagnosis, agreed upon policies and proper effective treatment. And there should be evidence of early detection and treatment, reducing the morbidity and mortality of the disease. That is the sickness and deaths due to the disease. And of course, C2 is the disease needs to be cost effective. And case finding should be a continual process. So what are the different types of screening? There can be mass screening carried out irrespective of individual risk, but these days it is being avoided for the cost involved. Then is the high risk or selective screening, which is the most productive and cost effective. And increasingly we are shifting screening for disease to screening for risk factors. That is, we are more and more shifting towards high risk screening. Then another thing is the multiphasic screening. It is application of 2 or more screening tests in combination to a large group at one time. So here is an example of some screening tests. In pregnancy, we screen for anemia, hypertension, there's pregnancy-induced hypertension, preeclamptic septicemia, toxemia, Rh status, syphilis through the VDRL testing, diabetes, that is to check out the gestational diabetes, cardiovascular diseases, neural tube defects, Down syndrome, HIV. In middle-aged people, we check out for hypertension, cancer, diabetes mellitus, particularly type 2, serum cholesterol, obesity, hypertension, as we mentioned again. Elderly group, we look at the nutritional disorders, cancer, tuberculosis, chronic bronchitis, glaucoma, cataract, and so on. Screening test needs to satisfy certain criteria. It has to be acceptable and reliable, that it has to have precision. That whether X is performing it or Y is performing it, it gives the same result. Then is the validity, that is the accuracy of the test. That is the mean value of the test will always be very close to the true value. And then is the yield. And the simplicity and safety of the test and the ease of administration of the test. And of course, it has to be cost effective. So let's see what is being accurate and precise. So if you see this first one, the dots are closely in at the center of the bullseye. This is accurate and precise. Because they are all together, they are precise. Because they are at the center of the bullseye, they are accurate. Now look at the second bullseye. It is clustering at the same place. That means they are precise. That is reliable, giving the same result on repetition, but not accurate. That is, it's not valid because it is far away from the center. Look at the third bullseye. The zoning is right. It's in the center, but it's scattered. That is, the test is not reliable. Look at the fourth one. It is the worst scenario. It's not accurate, not precise. The dots are scattered and far away from the center. So with that idea, let's come to the screening test scenario. So if a screening test gives high reliable and high valid results by giving the measured values very close to the true values every time. That is the best situation for a screening test. Then what are the other scenarios that may happen with a screening test? The measured values may be very reliable on repetition, but far away from the true value. That will give you a low validity but high reliability. Now coming to the third scenario, where the measured values are scattered from the true value. In that case, it has low reliability but high validity. Now coming to the fourth situation, here the repetition isn't reliable, the test results are far away from the true value, hence it has low validity, low reliability. And of course, in a screening test, as you can understand by now, we always prefer the first scenario marked with the red oval shape. That is, we want a high validity, high reliability screening test, where every time you repeat the test, it will give more or less very close values, and it will be always very near the true value. So validity is the extent to which a test accurately measures which it purports to measure. It has basically two components, specificity and sensitivity. These screening tests can be mentioned in two ways. It can be a two-stage testing or a simultaneous testing. Two-stage testing actually increase the specificity and reduce the sensitivity. And simultaneous testing, it increases the sensitivity, but the true positives are also increased. So an example of two-stage testing would be, first you go for probably urinary sugar, and once it's positive, you might try out the glucose tolerance test. So let us look at this 2x2 table to get an understanding of the screening test result by diagnosis. So the screening test results, if in one side the positive and negative test results are kept, and on the other side we compare with the diseased and the not diseased in actual, the first column, that is A, top first row and first column, that is the A, it represents those who are diseased and are also tested positive in the screening test. That is, they are the true positive cases. Now come to B. B are those who are actually not diseased, but they tested positive in the screening test. That is, they are the false positive cases. Now coming to C, in the second row, they are those cases who are actually diseased but tested negative in the screening test. That is, they are the false negatives. Now coming to D, these are the cases who are not diseased and tested also negative in the screening test. They are the true negatives. Now let's see what the test shows us is those who are having positive result in the test, supposed to have the disease, and those who are having negative results and supposedly not having the disease. But what doesn't show is the ones who are positive with the test actually consists of those who are true positives as well as those who are false positives. And it doesn't show those who are tested negative in screening can be false negatives and true negatives. So how do we evaluate a screening test? Usually the common evaluative measures are sensitivity, specificity, positive predictive value, negative predictive value, percentage of false negatives, and percentage of false positives. So how do we calculate this? If A is true positive, B is false positive cases, C is false negative cases, and D is true negative cases, then sensitivity is A by A plus C multiplied by 100. Specificity is D by B plus D multiplied by 100. Predictive value of a positive test is A by A plus B multiplied by 100. Predictive value of a negative test is D by C plus D multiplied by 100. Percentage of false negatives is C by A plus C multiplied by 100, and percentage of false negative is B by B plus D multiplied by 100. So let us again look at this through an example. Supposing we are considering a population of 10,000. The test reveals 40 people to be positive in the diseased one and 20 people to be positive in the non-diseased, actual non-diseased ones, and overall presents out of the 10,000, 60 people to be positive and 9,940 people to be negative. Whereas of the negatives, actually non-disease are 9,840 and truly disease yet tested negative in the screening test is 100. So that is so. Let us calculate the sensitivity. So here we will have 40 by 140 multiplied by 100. That is around 28.57% true positives in sensitivity test. Specificity will reveal the true negatives. That will be 9840 divided by 9860 multiplied by 100. That is 99.79%. The false negatives will work out as 100 by 140 multiplied by 100. That is 71.4%. False positives will be 20 divided by 9860 multiplied by 100. That is 0.2%. Predictive value of a positive test will be 40 by 60 multiplied by 100. That is 66.6%. Predictive value of a negative test will be 9840 by 9940 in this particular example multiplied by 100. That is 98.9%. So before we move on to some more details, it's good for you to know that all this sensitivity that we are talking about, it was a term introduced by Yerushalmi in 1940 as a statistical index of a diagnostic accuracy, and it is defined as the ability of a test to identify correctly all those who have the disease, that is the true positives. And 90% sensitivity means that 90% of the diseased people screened by the test will give a true positive result, and the remaining 10% will give a false negative result. And coming to specificity, the ability of a test to identify correctly those who do not have a disease, that is the true negatives. And 90% specificity means that 90% of the non-diseased persons will give a true negative result. 10% of non-diseased people screened by the test will be wrongly classified as diseased when actually they are not. So what is this relation between sensitivity and specificity that we learn to calculate? Whenever in a test you try to raise the specificity, the sensitivity goes down, and so rises the false negatives. Whereas if you try to increase the sensitivity, specificity goes down and the false positives increase. So basically the predictive accuracy, in addition to specificity and sensitivity, the performance of a screening test is also measured by this. That is the predictive value, which reflects the diagnostic power of the test. And this to a great extent depends on the sensitivity and specificity and the disease prevalence, the concerned disease. But if you look at it, any test for that matter has a cutoff value to keep away the false negatives and the false positives, get a better understanding of the test results. Often there is a bimodal distribution in the population, where here in this curve you see the curve in the left as the normal curve, the curve in the right as the diseased curve, and the point E is the cutoff line. If you shift it to the point A, what do? You take a lot of normal people to be diseased. That is, you increase the false positives. But if you shift it to B, you take a lot of diseased people to be normal. That means you increase a lot of false negatives. So either way you see, whichever way you shift, you are actually introducing error. In a unimodal distribution, again the same thing happens. In this normal curve, if we take the point D, that beyond it all points are representing the diseased population. If the point D is shifted to C, again that same thing will happen. A lot of normal population will be taken as diseased. So in variables like blood pressure, blood sugar, who are having this kind of distribution, their values are continuously distributed around the mean, conforming to a normal skewed distribution. In this observation, there is no sharp dividing line between the normal and diseased. So this borderline group, that is C to D, will comprise a homogeneous group of persons. This question arises whether the cutoff point between disease and normality are to be set at C or to be set at D. If the cutoff point is set at level A or C, it will render the test highly sensitive, missing few cases but yielding many false positives. If the cutoff point is set at B or D, it will increase the specificity of the test. Furthermore, in the unimodal distribution, once a cutoff point has been adopted, all persons above the level, that's whether C or D, it would be regarded as diseased. So let's take an example of diabetes. If the cutoff point for blood glucose is lowered to detect the diabetes, say let's make it 120 milligram per cent, the sensitivity of the test is increased at the cost of specificity. If the cutoff point is raised, say more than 180 milligram per cent, the sensitivity is decreased. In other words, no blood sugar level which will ensure the separation of all those with the disease from those without the disease. There will be problems of borderline. So in screening, a prior decision is made about the cutoff point on the basis of which an individual is classified as normal or diseased. So the factors affecting are the disease prevalence and the disease itself. When the prevalence is high in the community, the screening level is set at a low level, which will increase the sensitivity. On the other hand, if the disease is very lethal in nature, like cervical cancer, and early detection improves the prognosis, a greater degree of sensitivity, even at the expense of specificity, is desired. So earlier we had mentioned that one of the uses is the yield in case of a screening test. So what is this? It is the amount of unrecognized disease that is detected and brought to treatment as a result of screening. That is, yield is that part of the submerged iceberg which comes to your notice because of the screening test applied. So yield is true positive plus false positive divided by true positive, false positive, true negative and false negative. It depends on the prevalence of the disease and the sensitivity of the screening test. The yield of a screening test is high in screening. So another very important thing, but from examination point of view, it's more on the good to know side, not the must know. It is the receiver operator characteristic curve. It is to determine the best cutoff point for the screening test by means of this plotting. You plot the true positive rate, that is sensitivity, against the false positive rates, that is 1 minus specificity, for several choice of positively criterion. Choose closest to the top left corner to maximize the discriminative ability of the test. The area under the curve represents the overall accuracy of the test. The greater the area, greater the accuracy of the test. So if the test results are positive, what is the probability that this patient actually has the disease? Well, for that we have the likelihood ratios. A positive likelihood ratio, or LR positive, is the ratio of the sensitivity of a test to the false positive error rates of the test, that is 1 minus specificity. The higher the ratio, the better the test. So, likelihood ratio positive is A by A plus C divided by B plus B by D. The relative probability of a positive test in a diseased individual in comparison to a disease-free individual. The likelihood ratio negative, it is the ratio of the false negative error rate of a test, that is 1 minus sensitivity to the specificity of the test. That is C by A plus C divided by D by B plus D. That is the relative probability of a negative test in a diseased individual in comparison to a disease-free individual. And as for the evaluation of the screening test, the randomized controlled trials of screening tests to conduct the disease-specific cumulative mortality rate between the intervention and the control group is the usual. It eliminates the confounding factors. Next is the case control studies to evaluate. Here, comparison of screening history in disease and healthy is usually looked into. And in the cohort, the comparison of death rates between those who chose to screen and those who do not. In the ecological study, correlation of screening pattern and disease experience in several populations are looked into. And of course, when we are talking of screening, we have to talk about bias. The lead time bias is the overestimation of survival duration, which I discussed very early in this presentation. And the link time bias is the overestimation of survival duration due to the relative excess of slowly progressive cases in the disease concerned. And of course, there is overdiagnosis bias, counting harmless abnormalities as life saved. And selection bias, that is, people with higher risk of disease are more likely to participate in a screening test being out. So what are the points to ponder? People who participate in the screening program may not be those who have most to gain from it. Example, cervical cancer. Tests with greater accuracy may be more expensive and time consuming, and the choice of the test therefore often be based on compromise. The screening should not be developed in isolation. It should be integrated into the existing health services. The risks as well as the expected benefits must be explained to the people to be screened. Risks include complications and possibility of false positive and false negative. For your exam point of view, what is screening, types of screening, difference between screening test and diagnostic tests, the basic conceptual difference between screening, case finding and diagnostic tests, the methods of evaluation of screening, that is specificity, sensitivity, positive predictive value, negative predictive value, these come in your practical examination and you should be able to calculate them. Thank you so much. Please, if you are new to this channel, do subscribe
and press the bell button to keep yourself updated for every new academic content that I keep uploading for your benefit. And be a part of this community medicine family. Happy studying!